conference material. Let me describe first what our plan is for the next hour. We didn't want to have, as it's an informal armchair discussion, we didn't want to have a series of formal presentations. So we're going to start with a few questions that the panelists know that these are coming, so they mentally prepared themselves for this. And then we're going to turn it open for questions from the floor or from online. Grant is going to be trying his best to keep track of both the online and the from the floor questions. There's essentially one mic. He will read a question from online or bring the mic over to the person who has a question on the floor. So that's going to be a little bit hectic for Mike, but for Grant, but let's hope we can get through that part of it all right. There may be time at the end for a few closing remarks from our panelists. So I think all the panelists have been essentially introduced already by Mike's comments and by what you have in the conference material. So I'm going to go right away into the first open-ended kind of question that hopefully will get the panelists agreeing on some directions and maybe disagreeing on some of the details. But I think we'll go first into the first question, which is succinctly, could each of you please explain what you see as the data that are of greatest interest to the research community? Great progress has been made over the last 10 years in making health data available, but where are the gaps? Or to put it another way, what are the linkages that we're still not able to make with non-health data sets? And if I can piggyback a second related question onto that first, what does sharing that data actually mean? Does it mean giving each researcher a copy of the data, or could it mean something else entirely? So I'm going to start, as we had discussed earlier, with asking Ted to answer this question, and then Kim, and then Kathleen.
All right, thanks, Andy, and good afternoon, everybody. It's nice to be here, nice to see you all. So the theme of this is partnerships, and I think my first comment is going to relate to this is where one of the main reasons why we require partnerships to work together when we talk about bringing health data together for researchers. And I think I'll start with the Constitution and the separation of powers. And so as you know, provinces control healthcare, education, and social assistance. And the federal government controls many other things such as taxation and immigration and so on. But at the provinces where there's an enormous amount of health data collected, because that's the point of service delivery, the data collection that occurs there very much historically and continues to be based on the services provided rather than who they're provided to. And in the case of physician billing data in New Brunswick at least, it's really just about getting the physician paid. So what do we know about the patient from our administrative data that we have in the provinces? Well, we know age and sex and postal code and some medical history. And so I think the first gap and opportunity where we require collaboration is from the provincial perspective, the personal characteristics. Who are the people who are receiving services or not receiving service? Who are the people who are experiencing poor management of their chronic conditions? And this reflects things beyond age and sex to include ethnicity and other indicators representing EDIA groups. And there's so much interest in the provinces about how do we support better our vulnerable groups, but there's no data at the population level to actually help us do that work. Nova Scotia, just as an aside, I heard has just recently introduced BIPOC and Indigenous indicators into the Medicare health system, which is a big step forward as long as it's done appropriately and with the appropriate engagement. And in New Brunswick, as a bilingual province, language is fundamental. You have a right to receive services in French or English, in healthcare and education and income support. If the police stop you, you can test them and say, I want to be talked in French rather than English. But aside from some indicator in our Medicare registry system which says language of preference for communication in Medicare, there's nothing on language fluency and language preference. And so some of the work that we've done comparing to census data says that this underreports by about 10 or 15%. So as people, especially Francophones living in majority Anglophone areas, as they get older and they experience increasing language challenges, we don't know what the barriers are and the experiences and what the policy responses might be. And the third thing I'll mention from the provincial perspective, I used to be a labor economist before I switched into political science. There is very little information on what's happening in the labor market that's available to provincial researchers and provincial decision makers aside from StatCan data and ESDC data. So tax data are not available in our provincial data centers, and so we have to rely on things like social determinants of health. And this is something we're really getting into now, is occupation. Information on occupation is extremely limited, but occupation is so fundamental to our health and well-being. The interaction of conditions at work and your mental and your physical health. And so we have to try and be clever. We're looking at working with regulatory bodies. We're getting payroll data on nurses, government payroll data to try and fix this. But I think those are the two main issues when we try and think about the landscape and putting health in the context of social determinants of health are, who are you? What are your characteristics? And what are you doing? What's your work path? What's your family? What's your situation? Because we just don't see it at the provincial level. And I'll come back to the sharing once everyone's had a turn.
Thank you, Ted. Kathleen.
Shifting us up here. Okay, so I work at the Canadian Institute for Health Information, or CIHI. And I think it might be just helpful context to understand that, because it's a bit of a unicorn organization, as well as I've worked there for a long time, so it may actually color many of the comments that I make today. CIHI's mandate or vision is about better data, better decisions, and healthier Canadians. We're funded by all governments, provincial and federal, across the country through financial contributions. But we also get a huge in-kind contribution from the provinces and territories in terms of data. So it's just a bit of background. When I think of health data, there's lots that we know, and there's many things that we have huge gaps on. And I think a lot of those came to light during the pandemic. One of the areas is just basic supply data outside of doctors and nurses. So trying to understand the rest of the healthcare workforce, psychologists, mental health counselors, PSWs, really we have very little information on those, and it's a critical thing, as we sort of think about shortages and support planning for some of these professional groups where the training takes a long time. We also could use a whole lot more detail on the sort of frontline care that most of us experience from family doctors or nurse practitioners, and accessing, that kind of data, standardizing it and making it a public good, much like we have with our, health expenditures or hospital data, I think would be a real game changer in terms of understanding how healthcare works in Canada. And then a third gap area for me is around mental health of Canadians, including use of alcohol and drugs. While there's, I think, really good data, again, from the hospital sector on how people are treated for mental health and substance use issues, we know very little about community services or services covered by private insurers or the drugs that people may take to manage their conditions. And it's hard to know whether people are getting the care that they need or to understand the patient experience, or as Ted was speaking about, some of the equity dimensions. And I think most importantly, we don't know much about the outcomes. So we've had a lot of big shocks in the country over the last few years: pandemics, forest fires, now housing crunches. And those all come with, likely quite some deep impacts on mental health and substance use for the people who are affected by them. And I think that's an area where we really need to know more. So those are some specific topic area or types of care gaps. I think there's a few other gaps that would be what I would call cross-cutting. One of them is around the timeliness of the data. And again, it's all, timeliness is a fit for purpose kind of discussion. But a lot of the data that comes in slowly, and it's relatively old. And we're living in a world where things change very quickly. So, if you take old data to start with, and then the time that a research study takes, that can mean that the results may not be as accepted or as relevant, for current conditions. I think some of that's connected to the next cross-cutting theme, which is around data infrastructure. The pace of change in technology is crazy fast, and I think that impacts our programs in a couple of ways. One is the ability to get data in quickly, and then the other is really the systems that would make the data more meaningful and accessible in user-friendly ways, whether for health system decision-making or for research. So those are just a couple of areas where I think it's tough in a publicly funded setup to have the necessary investment. And it's not a one-time investment on technology, it's really an ongoing, evergreening issue that needs to happen. So I'll stop there too.
Kathleen. Kim.
Thank you, and thanks for the introduction, Andy, and for the invitation to be part of this panel. All three of us have a last name that starts with M, so I think I might have been invited for that reason, maybe, I don't know. So I'm gonna start just by thinking about when we talk about data sharing and the challenges of data sharing. I've begun to think that part of the difficulty with that conversation is that we never talk about what we actually mean when we say data or health data. And I think one of the big challenges now, and a huge opportunity, is what exactly is not health or health-related data? I mean, you've already heard like Ted talking about disaggregated data, social demographic data, but how you shop, where you shop, what your housing looks like, what your water source is, the social, political, economic context that you live in. As I was listening to some of the papers from the last session, the social and economic context that you came from if you immigrated to Canada. There's just about anything could be useful data for a research project, depending on the question you're asking and the things you want to consider in that. So that is, like I said, it's an enormous opportunity, but it also means that it's like boiling the ocean, right? So and one of the things that I started thinking about during the pandemic, when we were really focused a lot on data sharing, is that we really need to categorize things a little bit carefully, I think. And so one of the things is there's the data that aren't shared because they don't exist. And this is one of the things we really became very much to light during the pandemic, as Ted has already talked about. And both of the things that he highlighted, race-based information, occupational information, housing information, would have been very, very useful things to be able to draw on in the early stages of the pandemic, and were very useful for vaccine rollout in some places that were able to get their hands on that information and use it. But in fact, we mostly don't collect most of that. So this is not a matter of data sharing, it's a matter of a focus on the things that we actually need to organize in some way. Then there's the data exist, but they aren't organized at all. And I will just say, telling a little tale out of school, that in some cases in my province, some of the contact tracing information in the early parts of the pandemic was collected on spreadsheets and scraps of paper. So there's no hope of data sharing if that's the way we're going to organize our data collection systems. Then there's the data that are organized but just aren't shared. And there we can get to the sort of political and constructive conversations about differences that we need to make in mindsets and things like that. I'm sure we'll come back and talk about that more. And I think part of what I'm trying to underline in all of this is that there are more data available to us, or potentially available to us now than ever before. We also recognize as researchers the complexity of the problems we're trying to address in many cases. And that complexity and our commitment to still understanding causal pathways, because we want to know where to intervene in these things. It's not enough to understand associations, we actually want to understand causal relationships, I hope. I know that there's some parts of the world that don't necessarily care about causation. I think we all probably in this room do. So if you bring that all together, it means that we need a lot of variables. We need a lot of things in our models that will both focus on the actual relationships you're trying to test, but then also all of the potential confounding factors around that. So that means that probably no two research projects, if you were to design the most ambitious, perhaps unrealistic, but grandiose and beautiful research project you might design, I bet if you went around this room to 20 different people, the data sets that you would actually most desire, there might be 100 of them out there that we need. So we actually need to be designing systems that are nimble and flexible and able to draw in data sets that are maybe not routinely part of our collections in order to be able to feed this desire for researchers to really help us understand complex issues and to find complex solutions. So when we talk about data sharing, I'll just drop this and then I'll close my comments for now, but I do think that we want to think about data sharing as in making resources available in secure environments, in places, ideally not physical environments where people have to travel because there's all sorts of equity implications for that, but now we can make virtual environments, not handing out data on CD-ROMs and certainly not handing out data on a permanent basis because we owe a debt to the people who are represented in these data to use them in constructive cases for the public good with ethical principles and all those other things involved. So that's it for now for me. Thanks.
Thank you, Kim. Let's move quickly on to the second question because we are getting scrunched up. We want to leave enough time for questions from the floor. So very quickly, what are the main barriers and obstacles that are holding us back from, let's say, emulating other jurisdictions which are making more progress than we are? I mean, we've got made some good progress in the last, let's say, 10 years, but they're making more progress. So what's holding us back? And if we could, Kathleen, if you could start with this, and then Kim and Ted.
So I think one of the things that holds us back as a country is health. I mean, like Ted referred to this, that health is a provincial territorial responsibility as per our Constitution, and it's quite clearly that way. So we're really a coalition of 13 health systems, and they each have their own governance, they have their own legislation, they have their own data sharing agreements, they have their own practices. And then we have a federal government that also provides health services, to some Indigenous peoples, members of the armed forces, and presumably these result in data collection as well. So it's a lot of different groups to pull together. And I think that the other piece that we forget too is that 30% of the services provided are delivered by the private sector. So there's incredibly important information particularly in some areas, from private insurers, like who has health benefits and what's the impact of that on health system use. So I think that, particularly in areas like dental or mental health, those would be very big questions. There's also, so I think that that's one of the things, is that it relies on the goodwill of people to work collaboratively together, and that, many times that does happen, and from time to time, those things don't go as smoothly as we might hope.
So this is a great question. I'm going to breeze through a few things. So lots of people, the immediate reaction to this is that we need different legislation, and maybe that would help in some cases, but I don't actually think that I would put it at the top of my priority list. It's also, legislation change is also a very, very long process, so it doesn't fix problems quickly. I think Kathleen touched on this next thing I want to say. I'll just say it this way, that there's lots of players. There's lots of people, jurisdictions, organizations that need to be involved to make a good data system happen. And sometimes I think there's a lot of lack of clarity about who should be doing what. And that I think we can handle. There's also maybe sometimes a bit of territoriality, which I think we just need to be able to address head on. I think that there are some cases where there's researcher desires and expectations that maybe are a bit beyond what we can accomplish. I'm really interested in breaking as many barriers down as we possibly can, but there are, I would say that in a lot of AI community kind of conversations. The gist I get sometimes is that what people want is organized data that's just open and freely available at all times under all circumstances, and I don't think that that's a realistic expectation. So we need to be able to kind of, you know, work through what we can do and what we just are not going to be able to do. And then finally, I just really want to emphasize this piece, which I think is probably the most fundamental, which is that we have really worked with a culture of data custodianship rather than data stewardship. And what I mean by that is a custodian has a responsibility to keep data safe. So the custodial response will be the best way to keep data safe is to lock it down and never let it see the light of day, because then nothing bad can happen with it. A culture of stewardship, or the responsibility of a steward, data steward, is somebody who has to keep the data safe, but also is responsible for making sure that they are used to good effect to produce better outcomes for people and more equity and all of the other things that we want. So if we can switch to this idea of the answer is yes, as long as you meet these certain expectations, as opposed to the answer is no, unless you can prove to me that I'm not going to, that nothing bad is ever going to possibly happen, then I think we can make some progress. So yes instead of no, and away we go.
So when I got this question, I just sat down and I listed, just off the top of my head, 15 different reasons why data sharing is hard. I'm not going to go through them all. Many of them were mentioned. But I'll give you one vignette, I guess. We had funding and an opportunity to support clinicians and look at IV oncology, to gather IV oncology data for people with cancer and to help set us up for real-world evidence to see if drugs are actually working, if they're actually delivering the benefits. And we had to work with 2 health authorities. We had to work separately with each of 9 clinics, 2 to 3 different information systems that they used. None of the clinics had local resources. There was no consistency in what they captured. There was no documentation at all. So it's 4 years and counting, and we're still trying to put these pieces together. And that's just something that is so important for delivering timely health care for people who really need it. And this is just sort of one vignette and just how challenging it can be. And that's just within one province. And this is where the senior leaders of the province said, we really want this to happen. And this is how difficult it was. And I'll mention just 2 other things. One, I think I have to mention scale. So when Andy asked about data sharing. So if we take the simple example of, well, I have data and you have data, let's sign a data sharing agreement and I'll give you my data. So if we wanted to say link cancer screening data, which is each of the provinces, to federal data, to Stat Canada, CRDCN, we need 13 different data sharing agreements. If we wanted to link data from province to province for each of the 13 provinces and territories, we would need, and if we take this approach, we need 12 factorial numbers of data sharing agreements, and that's a really, I don't have the number, it's a really big number. So it's completely unrealistic. And so it then goes back to what do we think about when we say, what do we mean by sharing, data sharing? Because it can't be an enormous number of bilateral transfers of data for particular projects. And that's where things like, what do we mean by sharing? So distributed analytics and things like that. The third thing I'll mention, I'm involved in both CRDCN and HDRN, and I have been in both for a few years. And I've been on some national committees, and I was on the Council of Canadian Academies, the most recent report. And I'm amazed at how little awareness there is of researchers who use primarily provincial data about the federal data opportunities and vice versa. So if I can just involve a little bit of audience participation, this is a CRDCN crowd. How many of you know or have interacted with your provincial administrative data center in your province? Every province has one. And many of them have more than health data. This is a StatCan conference, CRDCN conference. This is not meant to pitch for the competition. But it's just an illustration that for so long we've got these different organizations working in the same space, trying to achieve the same mission, but not working together. And so I think in our third question, we can talk more about how we're trying to do that, because we have the right parties here. We have CRDCN and StatCan, we have HDRN and the provincial data partners, and we have CIHI. We can figure it out, and I think we'll get into that more in the third question.
All right. That's a good segue into the third question, which is, where are the solutions? And we've got some great creative organizations managing health data over the last while, both at the federal and provincial level. We have Canary with its new, CRDCN with its new RDC model. We've got a lot of the pieces are falling in place. Distributed analytics is becoming more accepted, and the technology people have worked it out. So we've got many of the pieces, but what pulls it together? How's this going to work, and what does the solution begin to look like? And most importantly, for this audience, is there a role for CRDCN in all of this? So if we could start with Kathleen, Ted, and then Kim.
Okay. So I think that we've talked a little bit about the maybe it's some of the limitations that technology removes. That I think that that's actually really been very helpful development. There's some questions I think that we'll still have to ask ourselves around technology, around, if we take data visiting and I have data and Ted has data, do I visit Ted? Does Ted visit me? How do some of these things work out? So I think that there's lots of implementation questions, but I think that the idea of sort of this data visiting or secure analytic environments or distributed analytics are here to stay. One of the things that we talked about earlier were some of the, I would say, like political tensions caused by just the way our health systems are structured and the lack of relationship sometimes between provincial systems or between provincial and federal systems. I think that's actually a huge opportunity for the Research Data Center Network, which is really, sort of a backbone for an alliance of 30-plus university groups. And I think that actually takes some of the politics out of the discussion and actually helps just with the conversation and helps to kind of get traction. I also think CRDCN has a hugely valuable role in the training of analysts and the support for people who are doing analytics locally. And some of that, I think, will sort of feed a workforce that's used to working with linked data and drawing on everything that's there to answer questions. So I think that'll be a very positive thing for the country going forward.
So yeah, there has to be a role for CRDCN. It's the main source of microdata on income and labor market activity, but increasingly, with the linkages that we see from provincial to federal, so through CIHI, hospital records and ambulatory care data are going from the provinces to CIHI to Statistics Canada, where they've been linked to all kinds of things. And when I ask my health colleagues about, if you want to do this kind of work, if you want to look at, say, the consequences of a health shock on income, or which occupations are more prone to, say, have mental health stress or leave, you can do it through the CRDCN, and the awareness just isn't there. And that's something that we can certainly work on. I think CRDCN can connect organization to an organization and develop those economies of scale and avoid so many of these bilateral negotiations, which waste so much money, so much time and effort. And then they can exploit those economies of scale. They can reduce duplication. And I'll just say, maybe as an example for where CRDCN might look, is HDRN, Health Data Research Network Canada, itself is not a data custodian, but it did lead the development of parallel data sharing agreements to get the CLSA, the Canadian Longitudinal Study on Aging data, into the provincial data centers in a linkable form, and it was done relatively efficiently. Similarly, HDRN is helping to expand IRCC immigration data into the provincial data centers. So there is a role for these central agencies to be kind of the data facilitator to make these happen in a consistent way but that spares the individual jurisdictions so much time and effort which they won't have time to do. That's one thing. I think as another expanded role for CRDCN, I think you really have to continue to facilitate data sharing agreements with StatCan among federal agencies. So there's already lots of work underway with the SDC, Health Canada, and IRCC. This is the right way to do it. And I think how you get, in my experience working with public policymakers for many years, hey, can I have your data? I'll do some really interesting research that you'll find interesting, doesn't play. Where we get traction in them putting resources into providing us data is when they have to do it for us to answer a question that they have. So with your programs of research, so CRDCN, where you've got these research questions that need data to be linked, that goes along with the research agreement, and that's how you get more data, which then becomes available to many other users. And I think CRDCN can take a more active role in working with provinces to get more provincial data into the RDC and available for RDC researchers. BC has already done that with K-12 data. I'll just mention two quick examples of what we've done in New Brunswick. So we work with the Council of Atlantic Ministers of Education and Training, and the project was they want to trace kids who go from a school system to the post-secondary or the labor market, and then post-secondary into the labor market, but they don't have data on kids. So we help facilitate a parallel four-province data sharing agreement to get K-12 data from each of the Atlantic provinces into StatCan, where it's been linked with all these data sets. And we've done some preliminary work, and it was presented to the Minister of Education in Nova Scotia, and he said, I want to do this every year. I'm all in. We want to get our data there every year. So when you can engage those policymakers and say, this is what we can do to answer your question, you get a lot more traction there. And we had something similar with post-secondary education, training, and labor. And then the third thing, I'll just mention this as a one-liner, I think there's a lot of capacity for CRDCN to be a data custodian in its own right. And maybe we'll get into that in discussion later.
So Kathleen and Ted have said a lot of what I might have wanted to say, so I'll just be really quick and say, first, yes, there's a role for CRDCN. I would reflect that over the past 10 years or so of my career, what I have observed is that it is very easy for people to do excellent work within their own organization or institution or health authority or whatever it is. It is a lot harder for people to do work across institutions and organizations, not because they don't want to, but because the structures are not there necessarily to support that or to reward that kind of activity. So that to me is the biggest thing for us to work through, is how to bridge things and work together as networks towards this idea of collective impact. And it's not a surprise then that CRDCN and HDRN both have network in their name. It is that very thing that we're trying to do, is to create bridges and opportunities where there just haven't been before. And I will just say Health Data Research Network Canada includes all of the data center and data center support organizations in all provinces, 2 of the 3 territories. We're working on the 3rd, and it includes Statistics Canada and CIHI as well. So this is a way that we can actually try to draw these things together and do something collectively that we can't do on our own. But it does mean being able to have really probably pointed in some difficult conversations about who's going to be responsible for what. Seems to me to be a completely manageable challenge, but that has to be one that everybody's willing to take on.
Thank you, Kim. Thank you all very much. Now it's over to you, both the online you and the here and present you. So Grant is ready. He's got a microphone. All he is looking for is a speaker.
I've got my
We'll
shoes
use
laced up.
that microphone and ask the panel, either individually or collectively. We have Martin up front, Grant.
Thank you very much. There are excellent comments. I just want to build on what was being said right at the end there, and that is the legitimization and the justification whether it's CRDCN or HDRN, getting into the business of advocacy. Because that's not the business we've been in. I mean, yes, in an some ad hoc fashion perhaps, with StatCan and so on in terms of data that we would like to see in the system, whatever. But the kind of advocacy that you're talking about now is much broader than that in terms of making system change. From a CRDCN perspective, and I think the same could be said, Kim, for HDRN, the legitimization in part comes from who supports us, which is in CRDCN's case, as you know, CFI is a major science initiative, 2 of the 3 federal granting councils, universities from coast to coast. So there's a lot there that in a sense legitimizes and justifies. But the question, I think, for me, from my past experience with CRDCN, is how best to do advocacy in the system, and particularly with the coexistence, and you've touched on this, Kim, of HDRN and CRDCN, who's responsible for what? Because otherwise we could quickly confuse what is already a somewhat confused landscape. Thank you.
Thank you, Martin. Kim? Yeah.
Thank you, Martin. It's a great set of comments on it. So let me start from the legitimization piece of things, because I think that's the entree to a couple other things I want to say. I think you're absolutely right. Legitimization does come in part from who's funding us, which is who you mentioned. I also think it comes from who is using services. So every researcher in this room that's used CRDCN as a legitimization, that's a really hard word, of CRDCN, and I feel the same about HDRN. I also think very, very wholeheartedly that it will come from the public as well. So part of my research program does public deliberation, and I've done some public deliberations around health data use and data linkage and complex data sets and combining public and private and that sort of thing. And the very, very consistent messages that come from the public are, number one, they want to see research happening as long as there's public good and as long as there's appropriate guardrails around who gets access to what for what purpose. Second, they really, really support trusted third parties and or data trusts and or intermediary data organizations, whatever you might want to call them, that are removed from government to do this kind of work of bringing these multiple different data sets together. Now, part of that has to do with more trust in universities and researchers than in government, for example, but I think part of it has to do as well with wanting data use and data access to be governed by policies that are not interfered with from a political process. And I'm happy to have a longer conversation about that. I'll leave that there. The last thing I'd say is how best to do advocacy, I think, is something that we should be talking about. I don't have an answer for that. I do think that it has to include the public in some way.
Anything else, Ted?
Well, between our organizations, we represent many thousands of researchers and many thousands of projects, and so we have credibility. And I think in terms of advocacy, we have a loud voice because of the research power that's behind us. But I think I'll just say that the successful advocacy for greater government, and if we take, there's advocacy across a whole spectrum of things, but if we want to advocate for government to use more data for evidence-based policy, which every government will talk about and few are serious about doing, and our own premier was quoted as saying, "Data my ass," when he saw some data that he didn't like. We had it quickly turned into T-shirts. Is that the research community, we need to recognize what government wants, and we need to move a bit in their direction, and they need to move a bit in our direction, because as long as we can understand what their problems are, then we have the credibility as not-for-profit organizations with superbly trained researchers who can deliver honest evidence. And whether they ignore it or whether they take it up, at least it's getting in front of them because they've asked for it. And I think that's one of the roles that the advocacy, which across the whole spectrum of things we can advocate for, is evidence into policy. And we have the tools to help you do it. And it's not going to cost very much. It's certainly going to cost a lot less than you get Deloitte or EY to do it. And it's got more credibility with the public. So the public trusts us more than they, even if government, and there's superb researchers in government, but if something comes out from with a government label, it's dismissed. And that's because there's a cynicism. But if it's through a university where we do have that reputation, we have lots of bad reputations as well, but we are credible, and we can advocate that we can do really good policy to support that. If there's a bit of infrastructure investment in terms of the data, we have the networks with the researchers, and we can actually help make a difference, which is what we all really want to do.
And maybe if I could just add on one thing, and I think it's to the point Kim was making, that the views of the public are powerful, and you've seen that in your own research for sure. But it's not necessarily a spread across the country, easy to harness kind of voice. And I think the more that we could do to actually create public demand, like the advocacy to have more public say-so or input to that kind of policy making in support of research, I think that would actually be a very helpful thing.
Thank you, Kim. Natalie, down at the front here. Here we go.
Did you want to go? You go ahead. Hi, great panel. So I have a few things floating around in my head, because I think, and this brings up something that you were all pointing to, the social challenges around addressing this, I think, are much higher than the technical challenges. We can find the ways in. But I was at a workshop for CFI, our funder, a week or two ago, where the focus was on how do we properly fund in a longer term way research infrastructures. But around this table, it's not a table, in these armchairs right now, we have two networks and an information institute, right? There's no sense of the research infrastructure built into this. So do we need to be supporting new infrastructures that can steward this data, or do you think that we just need to work with the players that are in the system? There have been a few different responses to that, but I'm trying to think of the pieces that we need. We need the advocacy that Martin talked about. We need the agreements. We need to make the case, as Ted said. Are there other pieces that are missing in this context?
Good question, Ted. Why don't you take a stab at it?
I don't know how much appetite there is for building another national data platform. I think we are the main organizations. We have a lot of infrastructure. We have a lot of funding. And as you said, infrastructure is becoming less important. I think the parties are here. We are the ones who can help sort it out. If we start at the end, which is to get more timely, high-quality data in the hands of researchers so that they can do good work that affects policy, then that's what our mission is. And I think we can be creative in how we share data. Technology is ahead of us there. And it's really just about socializing the ideas, getting people on board to be willing to try new things. But it's not to come up with a new infrastructure. We have our infrastructures. And in fact, we could probably do with a little bit less infrastructure. But it's the soft side of these things where I think we need to make the biggest gains.
Yeah, I would just say that also that the technology is expensive, right? And it's not a one-time cost. It's like keeping up with new technology developments, new security developments. Both the people and the hardware are expensive. So there's probably some limit to the amount of that makes sense for a country of our size.
And maybe very briefly what I would add is I think I probably at this point, at least from the research perspective, think less about the need for infrastructure and more about the need for different funding models. CRDCN has an MSI grant that many people who get CFI grants end up with an MSI, but they eventually run out. And then you're left with something that you can't sustain anymore. So we're very good at starting new things. We're not very good at sustaining the core things that are essential to multiple dozens or hundreds or thousands of researchers. So I think getting this idea of This is core. This is what we need at a baseline, and then if researchers want to get grants from CIHR or CFI to build on that, that's great, but we've got to, I think it's much more about defining the different funding model and the way to create a core that is consistent and doesn't have to flounder around all the time to find the next batch of money.
Can I have one more comment just on that? I think there needs to be more coordination from the funding councils. They are funding a lot of different initiatives where someone proposes to put together a data center or a data site to house data. There is so much duplication. And they're not even talking to each other. So I think the coordination has to be at the national level, still to meet these local demands, but I don't see enough coordination from the people who are funding us. If they want us to do this, we can sort it out. But it's just so, the funding decisions seem to be so siloed.
If I could just make an observation from the vantage point of participating in the Advisory Council on Health Infrastructure back in 1999. It was co-chaired by Alan Nymark, the late Alan Nymark, and who from Alberta. It'll come to me. And out of that grew the case for Canada Health Infoway, Inc., because something needed to be done with the province's involvement that couldn't be done within government. Alan was very familiar with the Canary model, and so he kind of looked for an equivalent within the health community in Canada. Likewise, for the first Canadian Council of Canadian Academies expert panel on this issue, the case was made for a new organization to be funded in order to promote some of the data availability challenges that Canada faced. In both cases, there was a real argument to be made for the creation of a new organization because the existing infrastructure couldn't do it. I don't think that case has been made in this instance. I think we have a potential solution. It has to be explored, developed further, but CRDCN could do it. It's arm's length already, and it's got the necessary linkages within the community. It has to do an awful lot of work to get there, but I don't think we have anywhere near the case for a new organization that existed in those other two instances. I think Byron had a
question in from online. Just a little one, Kim, directed to you. What do you think will be the role of AI in accelerating data generation and use? Just a bite-sized question.
I worry about AI generating data, actually, because we trust it. I think AI has actually been considered in something Kathleen mentioned early on in her remarks, which is speeding up the transmission of an event to data to availability for research. So AI systems to actually help hospitals do coding is something I've seen lots of people talk about. I think AI could be used in physician offices to actually substitute for EMR generation and could speed up data processes there. AI has been used for data quality, data checks, and data preparation. So there's lots of opportunities there as well. Of course, there's also potential for AI to be used to generate fake data, and all of those sorts of things. Here's an interesting one, though. I've also heard about AI being used to generate synthetic data, which can actually do things like help with the data sharing issue, because you can use synthetic data instead of real data, and it's very complicated the way it was described to me, but it seems like it works. And it can be used to augment clinical trial populations, so you actually can synthesize some people in clinical trials. And therefore, we could actually do trials that represent more of the ability to do disaggregated analysis by sex or gender or race and ethnicity without having to have all of the expense of a much larger kind of trial. So lots of opportunities for AI. We need to keep ourselves glued to making sure that it's actually being used for public good. But beyond that, I think that it is upon us, so we might as well take advantage of it.
Good. AI, nothing. All right, Byron.
Thank you. Excellent comments have been made. Am I amplified. Excellent comments indeed. I have a two-part question. Kathleen, I think it was you who said that more progress is being made elsewhere, and I'm just curious about where that elsewhere is. And my second question, and I think it was Kim who said that it's possible to come up with a realistic data request. I'd like to have your suggestions about what a realistic data request would be, and I have some suggestions. For example, it might include all the provincial data that are routinely collected and not now, at least not yet, made available to the research community more generally. That would be my, I think, first request in this general area. Thank you.
So I think it was Andy who said that we actually had other countries that were doing better. But I think like there's somewhere it's just the scale of the country makes it easier to operate with a smaller health system, right? So where the responsibilities aren't as distributed as they are in Canada. So I mean, there's lots of examples that you hear from the Scandinavian countries of things that work very well. You hear about the Netherlands, things working very well in terms of data and ability to. So I think it's not just on the data side though, it's on the care side and the research side. I think the smaller number of players, it's easier to reach agreement.
I want to say two quick things about that piece. So one is always beware of what you know, which is always more detailed in your home jurisdiction compared to what you're looking at, which might have a little bit of a PR layer to it. I kind of think of the UK is often held up to Canada as being like a place where they're doing so much better. I don't think they're doing better. They're doing better in Wales. They're doing great stuff in Wales, but that's one country in the UK. So I think that we have to be careful of the sort of PR effect. I do, however, think that Europe, as a European Union, is doing some really, really interesting things that we could learn from, including some pieces in the cloud independence and things like that that are at least worth understanding what they're doing and how they're going about it, because that is definitely bringing a number of different countries together in a way that seems to be pushing the envelope. On Byron's question, I'm not a data governor. I can't make those decisions, but I guess what I have some empathy for my colleagues in ministries of health and so on because of two things that have happened over the last decade or so. One is we have made a big deal about telling people that data are an asset. They are the new oil, which is terrible. Like, I don't want a new oil. Thank you very much. But so we've actually given them a lot of messages that would suggest that they should husband and protect and keep their data close because they might be able to make some money off of it or do some other thing. It's an asset, right? So that message, I think, has backfired in some ways. But the other thing is that there's lots and lots of talk about data sovereignty. And of course, that's in Canada, that's an important perspective from an Indigenous perspective. But I think lots of other organizations and jurisdictions are thinking about data sovereignty and wanting to maintain custody and control over the data that are from their populations that they feel some responsibility for. And I think we can set up things in a way that actually allows both that data sovereignty perspective and the use of data in the ways that we all desire to happen. So that I would take as the challenge for us.
In the CCA report, there is a section on international comparisons, and the committee was very keen on places like Denmark and Sweden because you get a universal number that follows you from birth to death, and why can't we learn from that? And so I made the point, well, we're not that kind of system. We should be looking to the UK or Australia or the United States where we have federations or confederations, because that's more realistic, and that's what the kind of thing that we face. And one of the points that came out of that report is that the solution to better data sharing in Canada cannot be led by the federal government. It can't be top down. It won't work, and I don't think the federal government's interested in doing that. It has to involve the provinces, the territories, and the federal government as a collaboration to work on it together. So I think comparisons with other countries, I think researchers go, well, why don't I just go online and get this fantastic data set? We can't compete with that. But if you want to get data in Canada, then these are the realities. So I think we have a role to kind of educate researchers and bring them along and helping us to solve the problems to get to the point where data are much more accessible. But we have to recognize our realities of being a confederation.
I've lost Grant. Where's Grant?
I'm in the back corner here, Andy.
Okay. Do you have another question?
I don't have anything from online. I mean, I have a question, but I don't want to take the mic from somebody else.
5 minutes left, and I'm going to give the panelists each just a minute.
Perfect.
To give some closing comments on the discussion, on the questions, on the direction, and what comes next. So why don't we start right here? Kim, Kathleen, and Ted.
I feel like I've said most of what I wanted to say, although I could talk about this for a long time, so if anybody wants to follow up, feel free. But I do really think that the collective work, collective impact, bringing organizations, networks, groups together, and really having frank conversations and trying to make some decisions. There's so much opportunity. There's more momentum than I have felt in this space in all of the years that I've worked in it. So I would like to grab that and go with it.
So maybe two things. I think building on Kim's comment, there's a huge interest in provinces and territories to learn from each other and just know more about what's going on in terms of both the data they're collecting, the programs that they're running, the outcomes that they're achieving. So I think that there's a lot of interest in this space, and it's just how you can do that without having a single organization or entity in charge is the challenge, I think, that we continue to navigate because people just generally don't like to be told what to do. So it's just how can you bring people to a table where it's a collaboration? And I think often the right decisions come out of those voluntary tables, and sometimes they take a while to stick across the country, but a lot of good work comes to that way. The other piece I'd say is that there's the one thing we haven't really kind of touched on at all is the workforce that's needed to use the data wisely and contribute to it. And I think that's actually a place where the CRDCN shines in terms of the access that students have to important data sets that are kind of real world data sets that they would use both if they pursue a career as a researcher, but also if they choose to work in a hospital or a health authority or a ministry. And that's a tough market. It's going to be a growing market. There'll be, I think, a huge need for that. And there really isn't a clear developer of that talent, I don't think, outside of CRDCN at scale, looking at sort of pan-Canadian data. So I just think that's a huge win for the RDC network.
So I just got the hook from Andy. So the only thing I'll say is I think the solution to figuring out how to fit all these pieces together in Canada is not going to come from the federal government. It's not going to come from the provincial government. It's going to come from our organizations. We are the doers. We need to figure it out. We need to come up with a model. So we need lots more people working together and moving away from the idea of competition. There's enough work for everybody to do. Let's put it all together. And it's a hard enough problem that I'm on the verge of switching from unpaid board member to demanding to be a paid board member, I think. Thank you.
All right. Not. All right. All right. Thank you. Good questions from the floor. And on your behalf, I would like to thank our three panelists for a great discussion. Good ideas. I think we actually got from beginning to the end. And we're on time, but could I invite your thanks then for the board members?
Okay, thank you, Andy, Kim, Ted, and Kathleen for your insightful discussion, and thanks to our attendees both here in person and online for your interesting Q&A. So my name is Amy DeBow, and I am the CRDCN's Director of Finance and Operations. Nice to meet everyone. I have 4 housekeeping items to run over with you today. So the